demonstrate examination of the wrist and hand today. I always find this a little bit difficult to do in such a short time, unlike the previous speakers who do with just one joint. I have to deal with multiple joints. They're all little. So we've got multiple anatomical structures, and any of those structures can be involved in some disease process leading to lots of pathologies and lots of diagnoses that you may need to make either in the clinic or in the exam situation. So there can't just be one examination of the wrist and hand. That would just take too long and be too complex. So even though the wrist and hand is complex, we need to make examination of both of these structures as simple as possible. And the way we do this is by screening. We need to screen, we need to look for any clues, any suggestions of the underlying pathology that we can then focus the rest of the examination on. Looking, not just casually, but observing carefully to see if there are any features of a particular diagnosis is incredibly important. Okay? Fortunately for us, that's the first part of our examination. And we can do that starting by looking at the hands side by side in these three positions. We can look at the hands with the palms facing up. We can look at the hands with the palms facing down. And then we can look at the profile of the forearm, the wrist, and the hand. Not like this with the fingers clenched, but with the fingers extended. Okay. And in these three positions, we're looking for abnormalities. There may be an absence of the normal cascade of the fingers, either with the palms down or with the palms up. We're looking for deformities of the wrist or the fingers, either localized swellings or generalized swellings involving one or more joints. We could be looking for wasting of the intrinsic muscles of the hand, of the forearm. Okay? All these things that we know from very much when we were medical students. Okay? I like this particular position because it's so easy to miss certain key clues and findings. And when you look at the profile of the forearm, the wrist and the hand, you might be able to pick up the cubital tunnel scar. You might be able to pick up the presence of rheumatoid nodules behind the elbow. You could pick up forearm wasting. There might be subtle deformities that you've missed in the fingers, but when you look at the profile, you might be able to see the very subtle ulnar claw. Occasionally, psoriatic patches that will go with an arthropathy of the hand. And the other thing that I like about this position is that it makes you stand back from the patient. It kind of makes you stand back sort of next to the examiner, and you can both look and you can tell the examiner exactly what you're seeing and what he's seeing. So it lets you sort of stand back and sort of observe carefully. It may be that this first part of the screening process actually gives you the diagnosis. But if it doesn't, you then move to the rest of the screening process, and this is the addition of certain movements. Okay? So you can look, and you can ask the patient to put their palms together, bring their elbows up, and you can assess wrist dorsiflexion. You can ask the patient to put the backs of the hands together to assess palmar flexion. And as Ben has mentioned earlier, elbows into the side of the waist, and you can assess supination and pronation. Okay? The nice thing again about this position is that not only are you seeing the range of movement, but you can also assess by the patient's features, their facial features, whether that range of movement is painful, whether it's uncomfortable, whether towards the end range of movement the patient starts to grimace. These are important observations when you're examining the hand. You can then go on to assess the movements of the fingers. Okay, simple. Ask the patient to make a fist, to clench their fingers. Ask the patient to extend. You can then look at the thumb. Ask the patient to flex the thumb into the palm, extend, abduct, adduct. You need to be looking for either complete loss of movement in a joint. You might find there's a reduced joint movement. It might be painful, as I mentioned earlier, or it might be abnormal. In the hand, you might get triggering. You may get subluxation of extensor tendons. You may get subluxation of the joints. These are all things that you need to be picking up on your screening process. In this case here, you can see complete loss of IP joint movement of the thumb. So we're thinking, is this a flexor pollicis longus rupture? Is it a severe triggering where the tendon is stuck? Or it could be a neurological problem. It could be anterior interosseous nerve palsy. Okay? So this screening process is focusing our mind on the rest of the examination. So at the end of it, you have a diagnosis. Great. You may have a differential diagnosis. Or, if you're unlucky, you may not know at all what's going on. And in the exam, the advice here would be not to panic, because in this situation, the patient may be giving you clues, or the examiner may be giving you clues, giving you suggestions as to how to progress. What you want to avoid is complete random examination, which leads you down the wrong path. So don't panic. If you're in the lucky situation where you've got a diagnosis, brilliant, great. You want to demonstrate those features to the examiner. Okay, so in a situation like this, where you've clearly got a diagnosis, you can go on and say there is bilateral symmetrical polyarthropathy, features consistent with an inflammatory arthropathy, the most likely one of which would be rheumatoid arthritis. You can highlight the features that you've seen. Diffuse swelling, radial deviation of the wrist, ulnar deviation of the fingers with MCP joint subluxation, deformities of the thumb, and even the presence of rheumatoid nodules. Okay. Again, another clinical presentation that you might see in the exam, okay, and just careful observation will ascertain that this is a first CMC joint arthritis. You have a prominent base of thumb that which we often call squaring. There's an adduction deformity of the thumb metacarpal. The metacarpal's in the palm. And there's secondary hyperextension of the MCP joint. Okay. You can then go on to assess that a little bit more. You can look at the movements of that thumb, as I mentioned before. And then you can palpate. Here you're palpating for localized tenderness around the first CMC joint. Not anywhere else in the wrist, not anywhere else in the fingers, but you can localize your examination to that joint. And then you might add some special tests. Axial grinding, compression test, although I would warn you just be a little bit careful because those tests would just elicit pain. And the one thing you don't want to do in an exam situation is cause the patient too much discomfort. We can apply this to other arthritic joints. Again, careful observation here will give you the diagnosis. Fortunately for us, the anatomical parts that we described before are all very superficial. So here, we can see deformities of the DIP joints. There's a suggestion of bony swellings that we know are called Heberdens nodes. If it's in the PIP, Bouchard's, there might be soft tissue swellings from the inflamed joint or from mucoid cysts. We can look at loss of movement. And a very simple way to quantify this might be the fingertip to palm distance. And again, localized tenderness. I'm sorry. Now, it may be that you've highlighted some abnormality, but there might be a selection of different diagnoses that have led to that. You have a differential diagnosis that you want to assess. This might be the case for finger joint contractures. Not all finger joint contractures in the hand are due to Dupuytren's disease. On the palmar aspect, you can get scars in the skin from previous injuries, from burns, that will give you a contracture. Yes, you can go to the layer below, to the palmar fascia, and contracture of that, Dupuytren's disease, will lead to this clinical picture. But you can go deeper to the flexor tendons, and tendon adhesions, contractures due to previous injuries or infections can give you a very similar picture. The joint itself could be at fault as a result of ligamentous injuries, like the volar plate or collateral ligament, or as a result of arthritis. And even problems on the extensor side, on the dorsal side, an extensor tendon injury or a neurological problem affecting the extensor tendons can give you clawing contractures of the finger joints. So where would you start? Well, looking, observing, we can tell the examiner, or we can annotate where and by how much the joint is contracted. We can look to see if there's any other clues on the skin with scarring, pitting, the presence of nodules. And then we need to do one specific thing. We need to see whether this joint is fixed. Okay? If it's fixed, then it would suggest the likelihood of a condition like Dupuytren's disease. But it could also be due to flex and tendon contractures, to ligamentous injuries, and severe arthritis. However, if it's not fixed, if you can passively extend a joint, then you might be looking at an extensor tendon injury or a neurological problem. You have to be careful, though, because those two conditions, if they're chronic, can lead to fixed problems as well. We can use localizing tenderness to determine what the pathology is. Dupuytren's, of course, is rarely painful, and it's unlikely to be tender. But we could have localizing tenderness to the extensor tendon central slit, to the collateral ligaments or the volar plate, to the joint or rounder joint in arthritis, or along the flexor tendon path. If you've got Dupuytren's disease, but you palpate in the region of the A1 pulley and it's incredibly tender, it might be that you've got two problems. So here we go. We've got this in the exam or in a clinical setting, and we've identified a contracture of the MCP and PIP joint of the little finger. There's no scars, but there is pitting, and this appears to be a subcutaneous thickening. When we've assessed it, there's a fixed deformity. But there is no tenderness, but we can palpate that cord. Okay? So in this case, yes, the diagnosis is Dupuytren's contracture. If you do have a contracture, and there's a suggestion that you want to measure the level of that or the degree of that contracture, you can get your goniometer out. Is this correct? Measuring the PIP joint with the MCP joint extended? No. Okay. You have to measure the PIP joint with the MCP joint flexed. Here's another example of a PIP joint contracture. But there's a subtle difference. The PIP is flexed, the DIP joint is extended. On the palmar side, there was no problems with skin, and there was an absence of cords. Was it fixed? No, we could passively correct it. Okay? These things can become fixed over a period of time, of course. Was there any tenderness? Yes, there was tenderness over the central slit insertion onto the middle phalanx. The diagnosis is Butonius. Okay. We can think, in any of these diagnoses we make, about carrying out special tests that we know are associated with that diagnosis. What test is associated with Butonius? Elson's test. Okay. We can go specifically through Elson's test because it's much better in a tutorial kind of group where you can get in close. So we'll do that this afternoon. Okay. Here's another PIP joint contracture. Take it from me, the little finger and the ring finger are flexed at the PIP joints. But there's hyperextension of the MCP joints. But the other notable finding here, of course, is this wasting. Wasting of the first dorsal interossei in the first web space, and there's scattering in between all the metacarpals. Okay? So there's wasting of muscles. Wasting of interossei suggests a neurological pathology. You're thinking the differential diagnosis here is an ulnar nerve problem. Could be higher up, could be cervical root, T1, could be brachial plexus, or it could be even higher than that, it could be a central neurological problem. So what does that mean we do with the rest of the examination? It focuses our examination down the route of a neurological examination. Now, I won't go this into more detail because John is going to present that next, but we're really going to be feeling for the patient's feeling now. We're going to be moving to assess the power of either the peripheral nerve muscles or myotomes, and then we've got our special tests. So that was the sort of intrinsic minus, loss of the interossei. The other pattern, the opposite pattern that we can get in the hand is intrinsic plus, where the interossei muscles are tight, contracted, possibly because of an inflammatory process like rheumatoid, an acute injury in the past which led to a lot of ischemia, edema, or it could be neurological. We need to know in that situation how to conduct Bunnell's test. Okay, something that we can do this afternoon, but really in Bunnell's test you're trying to assess the degree of PIP joint flexion in two positions, with the MCP joint flexed and with the MCP joint extended. In a normal hand, the degree of flexion is basically the same in those two positions. In intrinsic plus, when you extend the MCP joint, you reduce PIP joint flexion. Okay, simple. We can go through that later this afternoon. Here's another clinical presentation that you might see either in the clinics or in the exam. We've got loss of MCP joint extension in the ring finger. It is passively correctable, so it's not a fixed deformity. We need to have a differential diagnosis for that. Is it an extensor tendon rupture? Is it that the extensor tendon subluxed because of a sagittal band tear? Is it that the joint subluxed because of an injury to the joint? Or is it because of a nerve injury, a posterior interosseous nerve palsy? It's unlikely to be that, of course, because all fingers will be affected. But the other thing is, careful observation highlights something else, doesn't it? There is swelling along the course of the extensor tendons and around the wrist. So it's likely that it's an extensor tendon rupture. When you've got an extensor tendon rupture, whether it's EPL or EDC, they might ask you to conduct one more test. What test would that be? If it's not a nerve palsy. You're thinking about future management. You might want to know whether there's an extensor indicis proprius. So you want to do that horn test, okay, where you're assessing to see whether there's extensor indicis proprius or extensor indicis minimi, okay, because you're isolating EDC. You're stopping EDC from working. Good. During your screening process, you might identify this problem, okay? So we've asked the patient to move, and that we've noted that there is loss of dorsiflexion, there is loss of palmar flexion, and there's even loss of supination pronation, okay? And we've also noticed that the patient shows some distress or some pain at the end range of movements. Okay? So this means that we now have to focus on an examination of the wrist. So we move to palpation. Look, feel, move. Now, with palpation, we're trying to identify any localizing tenderness, because the position or the area of that localizing tenderness will give us a guide to the possible pathology deep to that tenderness. So we need to know our surface landmarks. And this will take us about 5 minutes this afternoon to go through all the various surface landmarks to the relevant anatomy of the wrist. I'm not sure either. Okay. Well, once we palpate and assess this localizing tenderness, we can go and assess movement in more detail, because we've not assessed radial and ulnar deviation. So we can add that to our examination, and that might give us hints towards the underlying pathology. And then we go to all these various special tests, okay, that we need to know. Okay. We're looking at the Kirk-Watson test, scaphoid shift test for the presence of a scapholunate ligament injury. We can look at ballottement of the distal radial ulnar joint for instability of this joint, or compression for arthropathy of the distal radial ulnar joint. We can look at ballotment between the lunate and triquetrum to see if there's any instability between these two carpal bones. We can carry out an ulnar carpal stress test to pick up problems with the TFCC tears, or ulnar carpal abutment syndrome. And then we can look at the pisiform triquetral joint. It's one of my favorite problems to identify in the clinic, because it's often missed because people forget about the fact that it's there. But simple localizing tenderness with compression of the pisiform triquetral joint can be very painful in the presence of arthritis of this joint. So we're going to go through these tests later on this afternoon, okay, in a little bit more detail in small groups. Good. We do obviously have to know some other specific tests that are associated with hand examination. Here's an example that when we observe the hand, this is a normal attitude of the thumb. Here, the patient can't extend the thumb. And we can ask the patient to place the hand on a flat surface and actually then ask the patient to extend fully. It's not just a matter of extension, it's extension, abduction, it's retropulsion. And the loss of retropulsion will give us the diagnosis of an extensor pollicis longus rupture. And then you might want to assess whether there's EIP present. Okay? Here you can see swelling on the radial side of the wrist. This is the area where the patient's been complaining of severe pain for many months. What test may you consider doing here? Finkelstein's test. That's Finkelstein's test, isn't it? Thumb in the palm, fingers over the top, passively going to ulnar deviation. Patient hits the roof, and you failed the exam because the patient's crying. So you need to be aware about being kind to the patient. And if you do have, you probably wouldn't have this kind of patient in the exam, it's just too painful. But you can do Finkelstein's test much more gently, just by having the thumb extended over the fingers, and then just very gradually, very comfortably going into ulnar deviation. Okay. You may find that when you screen the hand, I normally do it with my middle finger, but I don't want to be rude today. You might find that the normal cascade is absent and the index finger is pointing, okay? And you might find there's a scar in the palm of the hand or some evidence of injury in the past. And then you ask the patient to clench and this finger stays put, it doesn't bend into the palm, okay? What do you do next? Well, you suspect a tendon injury, don't you? So we need to be able to assess FDP and FDS. FDP is easy because all we have to do is isolate the DIP joint and ask the patient to flex that joint. FDS is a little bit more difficult because FDP would flex the PIP joint. So we have to exclude FDP, and fortunately we can do that because it's one common muscle belly with 4 tendons. So if we isolate the other 3 tendons, we can stop FDP from contracting, and that way the only tendon that can mobilize the PIP joint is FDS. Okay? And in fact, the DIP joint is completely floppy. The other important thing that you may be asked to do is not just give a diagnosis, such as here, but you might be asked to do a functional assessment of the hand. So you have to have some tools available and ready to do this. You need to have a coin, a pen, and a key. The coin is useful to assess not just chuck grip, but also when you ask the patient to pick the coin from the table, it requires a degree of dexterity, which you can assess. a key to assess side grip or key grip, and a pen for end grip or pencil. There's one other thing that you can do, is you can ask the patient to grasp your forearm to assess grasping. Okay? So functional assessment may be one thing that you're asked to do even in a case which is so complex that you can't give a diagnosis, but you can still do this. So, in summary, screening is absolutely vital. Okay? It may give you the diagnosis almost immediately, and you just have to demonstrate those specific features. It may give you an idea of the differential diagnosis that you then have to go on focused examination on. But if you're screened and you've had no idea, start to listen to either the patient or the examiner for clues. Thank you.
Those of you who want to stretch, you can stand up and stretch a minute or two if you want to, whilst we wait for the next speaker, John. We'll leave questions till later, yeah? You don't have to.
Okay, so it's nearly lunchtime.